Hi, welcome to Playing with Fire podcast. I'm your host, Brian Spitulski, an ex-firefighter and a current fire investigator. And I have a very special guest today, which ties into some of our previous episodes going back to PTSD. Sarah Ray Andreski is a psychologist,
hmm
and
Yes.
she will be listening to some of the topics and some of the events that we've spoke of in the past, and hopefully getting an understanding of what PTSD, why it does what it does to a lot of us. Now, I've asked a couple of my friends, one of them who was on here previously, if he would be interested in attending with us, and there was a little bit of a hesitation. So this is going to be you and me talking. I'll bring up a couple of scenarios. One of them is personal to me, and the other one is we'll just say a hypothetical scenario,
Sure.
because I want to understand what's going on. And I think that the people who have PTSD, which are almost everybody, I mean, honestly, in our circle, if you're a first responder, you have it one way or another. It seems like everybody we've talked to seems to have that. So let's get into this. First, give us a little bit about who you are and your background, if you don't mind.
Sure, of course. So, as you mentioned, my formal title is Dr. Andreski. Please call me Sarah Ray. I'm very informal, but I'm a clinical psychologist and I've been practicing since 2014. I did all of my 5 previous years of training and things like that with the Veterans Affairs. So, my background and how I chose my specialty areas was actually with an emphasis on military and first responders. And so, my entire career up to this point has been spent in these populations.
Awesome.
So I've done everything from, I have kind of a dual track specialty. So I specialized in what's called physical medicine and rehab. In plain terms, that's catastrophic physical injury. So massive burns, blindness, amputations, spinal cord injury, and disease.
Wow.
And then my other specialty was trauma. So post traumatic stress. And I dual specialized all the way through my training. And I've maintained a foot in both camps, probably more 70% trauma, 30% injury at this point. But that's kind of been my whole clinical background. So I've been working in this field in some form or another since about 2004.
Awesome. And as of that, I thank you for doing that. I know I have a lot of brothers and sisters that are struggling with it. Let's just cut to the chase. What's wrong with me? I'm kidding. My wife just
Okay,
about lost it just now.
rapid fire. I've got visual aids. I can jump right in. It might be my first podcast, but this is
Yeah.
not my first rodeo.
Gotcha. Gotcha. Okay. So I'm going to start with a scenario that I'm very familiar with because it still resonates with me. And then maybe we can kind of break that down into a couple of different things of how you would look at it, something that would be helpful. And being part of the VA, do you still use resources that the Veterans Administration puts out, or do you have different thoughts? And the reason I'm asking is if we have people who want to have a resource to look at, would you be able to
Sure.
provide us with some stuff that we can tie into the end of this podcast?
Absolutely. I can happily provide resources. I'm glad you asked. And then also, I forgot my ethics requirement is to say that this is not in any way affiliated with the VA. I'm on leave today and I'm not here as an official VA representative. Part of the fun of being a federal employee is you have to have that caveat in there. So,
There
but
we
yes,
go.
I can absolutely provide all sorts of resources and also provide some links to some of the demonstrations that I may end up doing today. So if somebody's listening as opposed to watching, they can
Oh,
go
wow.
back and catch some of those demonstrations as well.
That would be awesome. All right. So, sitting back in my chair, getting comfortable, the one that comes most vividly to me is always in the back of my mind is a vehicle accident that we were called out to special. So, when I worked for Modesto Fire Department, I was on the hazmat rig. Back in '02, one of our hazmat county resource partners got into an accident. He ended up dying in the van. He burned to death in the van. The county called Station 3, which is our hazmat station, and asked the captain on duty at the time, would he want us to respond out to this incident because Ken, who was a friend of ours, they wanted to know would we prefer to do what needed to be done with
Mhm.
the van. We had to secure some equipment, we had to extract Ken from the van, a couple other things. So the captain said, absolutely, we want to go, which I'll tie this in later. That was a problem in his mind up until just recently that he volunteered us to go. And I'll build on that in just a second. So We respond out to the incident, which is out near Patterson. My engineer, Antoine, and I, we're in level A suits, and we walk up to the van because one, the van burned. Two, there was radiological equipment in the van. So we were concerned with exposures and it couldn't just be hauled away. So we had to extract that equipment. And Ken was still in the front seat, the driver's seat. What happened is he went basically head on with the cement truck. He died instantly. The cement truck blew off, went to the side of the road, and I think he was injured pretty bad. But Ken was still in the driver's seat. So when Antoine and I went in, the first thing we wanted to do was get the equipment out of there so that we could do the right thing for Ken. And that was going to be the closeout of basically the incident, the van. We would take Ken from it. We would escort his body over to the coroner's vehicle and then be done with it. While we were in the back of the van, we found brain matter and head parts of Ken, which was extremely difficult. It was very difficult on Antoine, which I didn't realize how much it was on Antoine until afterwards. So we got the equipment out. We went and extracted Ken, which, if you can imagine, he'd been in the fire for a very long time. So it was a little difficult getting him out, and putting him into the body bag was a bit of a challenge as well. We took him to the coroner vehicle and they took him to whatever they do. And then Antoine and I, it was very quiet in the engine on the way back. We were kind of processing the whole thing. Chuck, God bless him, he was having a hard time too because he knew Antoine and I were having a hard time. So his ghost in the closet is, should we have gone? Because had we not gone, one, we wouldn't have been exposed to that. Two, down the road, flash forward about 5 years, Antoine ends up dying from a drug overdose, which is kind of weird. He ended up medicaling out of the fire department. It was tied directly to this incident. He got a divorce, a couple other things that had happened, but he ended up passing away, which I didn't realize until the funeral that Antoine had reached out to a couple of his best friends saying, my life has never been the same since this incident, which is very difficult because shortly after this incident, I went into investigations where I was Ray's partner. I was no longer online as much, so I didn't see Antoine as much. And there was one time I went and saw him at Station 3, and he pulled me to the side and said, hey man, I'm having a hard time with this incident. I keep seeing Ken. I keep seeing what we saw in the back of the van. Mm-hmm. And it was very rough on him, but I didn't realize, and this is my ghost, how tough it was for him to not be able to talk about it. And I've talked to my ex-captain a couple times, and he noticed, but didn't tie it to the incident, some things that were going on with Antoine as well. But he didn't understand the impact that this incident had on it. So having now heard this, and you see, it's emotional for me right now. What is going on? I mean, I feel my thing for Antoine, and I'm sad for him, and I feel a little responsible. Now, Chuck felt responsible because he took us to the call, and it wasn't until the interview that we had that he asked me, what if I didn't take you guys out there? This wouldn't have happened. And I told Chuck, I said, this would have been more upsetting to me had you not taken us out there, I think, because Ken was our friend. And we took him out of the van with more dignity and respect, I think, than just a coroner would have done, just pulling him out. So I hear from Chuck that, he appreciated that because in his mind, he was always holding himself responsible for it. And it wasn't until that interview that he felt better about it. I understand the emotional tie to this, but what is the thing that's going on in me right now that this was 23 years ago that this happened, almost 23 years ago. Why am I still crying about it?
Because it still lives up here. So thank you for sharing that with me. So when people ask me, like, what do? I tell them, I say, people tell me the darkest days of their life. And it's always a huge honor to be in this position. And it also just makes me really sad that this job exists.
Right.
But if I may, and I'm going to do my best to walk through this. This is a visual that I draw for all of my patients, usually in our first session. I'm going to do my best to audio explain it as well for listeners who might not be watching. but I'm gonna walk through this with you to show you what's going on in the brain. So when someone is exposed to a trauma, the processing part of it starts. Think of processing almost like chewing, right? The problem is there are things that we have no blueprint for. There's no script for how to process seeing your friend's brain in the back seat of a car. There's no script for that. And so, have you ever had a song stuck in your head that just wouldn't get out of your brain?
Yeah.
Okay. So, we're going to walk with that example. All right. So, as best as I can, I need to invest in a clipboard. I've only been doing this for 20 something years and I haven't done it yet. All right. So, I want the listeners to picture the no sign. So, think of like a no turn sign. So, a circle with a line through it. Okay. The front top portion of that sign, I want you to think of this as the front corner office with a view. This is the front part of your brain. So I'm going to draw like a little tiny office right there. And then this back part, so the bottom part of the no sign is what's called, we call it the lizard brain, right? This is the experiential part of your brain. This is the part of the brain that you share with a gecko. Okay. So this part of the brain controls things like your brainstem, your pulse, your oxygen, what tells your heart to beat, what tells your mouth to breathe, your lungs to breathe. This part of the brain develops first. So when you're developing, the back part of the brain develops towards the front. Now, we're going to offend a couple people here, so buckle up. In adults, this part of the brain, the front part of the brain, in women tends to develop around the age of 22. In men, it's closer to the age of 26 or 28. So you have all of this stuff back here that's developed that's teaching you how to be alive. And then this front part of the brain is your meaning maker. So this right here, this little office, if you picture that front corner office with a view, picture Jiminy Cricket living in there, right? So always let your conscience be your guide. This is the part of the brain that makes sense of things. It's the part of the brain that talks about your morals, your belief system, your core values, how you interpret what happens back here. So again, if you think of this like a no sign with a line drawn through it, the bottom part of the no sign is all the information to live. It's just facts. That's all it is. So how does this incorporate into post-traumatic stress? What happens is back here, think of this like a sports camera. And I'm doing this backwards, so bear with me, right? So when you see a trauma, when you see information, this camera gets activated and it takes 1 million pictures and it uses all of your senses. That's why you talk about, Vietnam vets talk about hearing the helicopter sounds. You mentioned hearing bagpipes, smells, all of those sensory information, all of that gets taken pictures of. So think of these pieces of paper. How this works is the factory floor. So from the bottom of the no, so of the no sign, up to the front, to this front corner office with a view, the executive part of the brain, the executive sitting in the office, this information is supposed to come up here. And this meaning maker makes sense of it and it puts it in a giant file cabinet.
Okay.
All right. So what goes into this file cabinet is your likes, your dislikes, your favorite color, your favorite music, that song you hate, food allergies, all the way up to all the reasons why you love your spouse, right? So this file cabinet holds everything. It takes this plain, factual information that's not emotionally charged in any way, and it charges it. It gives it an emotion and it gives it a place to live. Now, that big no sign that comes across the middle of it, this is post-traumatic stress. Think of this like the Great Wall of China, all right? This comes into play when this factual information back here. Now, where this gets tricky is people will say, well, I know for a fact it's my fault. That's where my job comes in and I argue with you. We're just talking about basic details back here. These details can't get to the executive because the executive says, I'm too overwhelmed. It's too meaningful. It's too hard. I can't make sense of it. And it pushes back. So this Great Wall of China comes in here. And this is where post-traumatic stress comes into play. So this is where you have what we call avoidance behaviors. And it's not always intentional. It's not that someone's purposely trying not to think of something. The brain will go to great lengths to protect your body from suffering. So it will do things like push away the thoughts. It will go to extreme measures to push away the thoughts, either through addictive behaviors like substance use. I don't know if we can say pornography on the podcast, but that's something that's really rampant in post-traumatic stress populations. It's something that they struggle with, right? It's looking for a dopamine hit. It's engaging in reckless behavior, aggressive driving. That's why you see so many people coming from the military, going into fire, going into law enforcement. They're looking for that dopamine hit, that adrenaline high. And so what happens with this no sign, none of this information gets processed. This is the song that's in your head that won't come out. The brain does not like unsolved puzzles. It will continuously play this song on loop until it finishes the song. And so what happens, you have what are called intrusive memories, which is where that memory plays and plays and plays, and it's suffering. And so people will stop the suffering, whether it's through substance use, emotionally withdrawing from their partner, any of those things, in an effort to make the song quieter.
Block
it's to
it out.
quiet the noise. Yep. And so what happens with therapy comes in and sits on the wall, and it creates a place to process this information and what's happened and the meaning that you have assigned to it and whether or not that's accurate in a way that prevents you from feeling flooded. So therapy comes in and creates a leak in the dam, as it were, as opposed to a flood.
Okay.
And so it allows for this information to come forward, to be processed, to answer those questions that keep you up at night. Like your captain saying, like, should I have done this? Should I have sent you guys? Was it my fault? What could we have done differently? All those questions that haunt you at night, that's what the therapy comes in and helps to stop this process. So you mentioned partnerships and things like that. You mentioned that Antoine went through a divorce. All of these behaviors, this PTSD is expensive, right? Post-traumatic stress is expensive and it takes a toll, and the ripple effect spreads wide.
Yeah.
And so this process impacts everything. So one last demonstration here, courtesy of my toddler. We've got a rubber duck because easiest thing I could find. So if this is the person who's experienced the event, right? If this is the fireman, or in most of my clinical experience, the military veteran, this is the person. They're living their life. And so I ask the person in front of me, I'll ask my patients, is this you? And they look at me like I'm insane because it's a duck, right? But here's this glass. Are you living your world like this? So here's this person who's experienced it. And here comes their spouse, because their spouse just had another Tuesday. They didn't do all of these things that you experienced. And they want to know why you didn't fix X, Y, or Z project. And they want you to know that your daughter's got her Valentine's Day dance coming up and your son needs new shoes. And you're sitting there saying, I just did these horrendous things and saw all of this. And they're saying, well, what's for dinner? Right. And so they're knocking on this wall and you're observing your world, but you're not all the way in it. And that could be because emotions shut down, because the nervous system doesn't differentiate between good emotion and bad emotion. It just shuts down. Or substances are numbing things out. Distance is being created in the relationship through extra affairs or internet usage and things like that. And so what everyone else sees is this person. They don't see the glass. What you feel is this. This gets old quickly. And unfortunately, people will take extreme measures to not feel that way anymore. And that's why we see substance use. And unfortunately, sometimes the accidental overdoses that come in and claim lives.
Right.
Or the people that take their lives on purpose.
Okay. So if PTSD in a scenario where there is a person interchanging or has that directly in front of them, that impact moment, there is also PTSD where a person is, I'll give you another scenario. A friend of mine, an Army buddy of mine, had his best buddy who was a sheriff's officer get killed in the line of duty. He has what I would consider PTSD because that triggers an emotional thing with him, and he misses his brother dearly, and it does bother him a lot. Does that associate to the same thing that you were just putting out, or is it kind of a different setup?
It's exactly the same thing. We actually have a term for it, and it's vicarious traumatization. And so the vicarious part is that you're reliving the trauma through someone else. We see this with 911 dispatchers, right? So they're not boots on the ground. Right. They're not seeing, but they're hearing. They're being exposed. So we can also see this coming up with medical transcriptionists who are writing the notes out that the doctor is dictating, vicarious trauma. We also see something called secondary traumatization, which is, we see this generationally. When this first started to be researched, it was with survivors of the Holocaust, and it looked at how PTSD was almost being passed down generationally. And when I did my dissertation in graduate school, I actually went backwards a generation. So I looked at the parents of combat vets returning from war and how that was impacting them and giving them symptoms of post-traumatic stress, even if their child in front of them wasn't necessarily outwardly injured or moving even back in with them. But it's looking at the contagion factor of post-traumatic stress and how any kind of exposure to that information, it doesn't just have to be visual. So when we look at the diagnostic criteria for diagnosing someone with post-traumatic stress disorder, the first thing that you're looking for is what we call a criterion A trauma. So it is seen, heard, witnessed, experienced, or become aware of something that's traumatic, life-threatening, limb-threatening, safety-threatening of a loved one. So it doesn't just have to be directly experienced. It can be experienced through the traumatic loss of someone else. So someone being traumatized by a crime being committed to their loved one, or, a motor vehicle accident, something like that.
Okay. My wife, being from the law enforcement community, she was very involved in the honor guard. And usually honor guard is when somebody passes away. And when somebody passes away, they play bagpipes, either for fire or for police. They have a tendency to do that. She would go back to the law enforcement memorial in Washington, D.C. For me, those are triggers because it brings back that Antoine moment. It brings back that Ken moment. What do I do to make that less of a trigger and more of a moment I can honor that moment than to push it into a corner and not pay attention to it? And I'm not going to go, so I'm just going to stay over here and not go to Washington.
Exactly. So what you're describing is an active avoidance, right? An active avoidance is you're trying to avoid the trigger. So by not going, and then there's the emotional distance that's created, there's the guilt that's coming up from not participating in something that's meaningful. And so going back to our diagram here, the bagpipes, that's a sensory information. That's one of those pieces of information that's written in the back part of the brain. And anytime the executive up in the top hears it, he's like, nope, nope, nope. That's the post-traumatic stress. And so clinically speaking, in broad terms, obviously I'm not your therapist, so I'm going to make generalizations here. I am trained and certified in all of the gold standard therapies for post-traumatic stress. And the main ones that we use are cognitive processing therapy, prolonged exposure therapy, or what is called EMDR, which stands for eye movement desensitization and reprocessing. So CPT is cognitive processing therapy. There's an exposure component to that. So you're writing out what happened, and then you're going through a cognitive process of it. So you're looking at the thoughts and the meanings and the beliefs that you have, and you're comparing them to create some space around it to see if there's some room to move through some of that guilt or some of that self-blame. And a quick side note. So post-traumatic stress, the way I explain it to folks is that it impacts the way that you view yourself, those closest to you, so like your loved ones, and the world around you, so your environment. Cognitive processing therapy looks at how those three things have been directly impacted by what you have experienced. It examines that, and then it goes through a process to evaluate the emotional components and the cognitive components to see if we can create some space for some healthier belief systems to move in, is kind of the best way I can explain it in easy terms.
Okay.
I like prolonged exposure therapy for folks that have very specific triggers, right? Very specific triggers that they need to work through to be able to get back out and do their jobs. I used prolonged exposure therapy a lot with active duty military when it was like, okay, you're having a reaction to water was a big thing when I was working with the Navy. And so we would actually put wetsuits on, grab surfboards, and not literally drag, but kind of them out into the water. And we would do prolonged exposure sessions in the ocean on surfboards.
Okay.
Nothing like just really putting them in there.
Right.
I also didn't know how to swim when I took this job. A Marine taught me how to swim, and it was not the way to learn, I'll tell you. But that's a story for another time.
That's probably how he was taught.
Pretty much.
Thrown
pretty
in
much.
the water.
And so EMDR is, in this instance, what you're describing is what I would recommend. EMDR has gained popularity in the last several years, and it's a great therapy. It works for many things. It was originally designed to help with processing trauma. But the way that EMDR works is that it looks at what is the trigger, and it helps through bilateral stimulation, which I'll explain in a second. It helps to prevent you from becoming overwhelmed by doing the exposure. So the exposure therapy process is to expose you to the trigger either imaginally or in vivo as many times as we can, because your body will naturally stop responding as heavily to it. EMDR brings that in, but through the bilateral stim process, it reduces that sense of overwhelm and that sense of flooding and that panic of, I can't do this, I need to avoid.
Mm-hmm.
It comes alongside, it prevents it from reaching that threshold. And at the same time, you are incorporating new belief systems, new cognitive processes. So new memories of, what do bagpipes mean to me now? And so we can present that trigger, and the emotional response, the physiological or physical response, is significantly less noticeable. And there is space for something else to come in alongside of that.
Okay.
So the bilateral stim process is done through either eye movements back and forward. I like to use tapping because a lot of my guys have brain injuries, and so the eye movements can get tricky. But what you're doing with that is you're essentially getting blood and oxygen to cross the blood-brain barrier in the center corpus callosum in the brain, to make it so that you're getting blood flow to both sides of the brain, the emotional, the logical, all the different components, so that Jiminy Cricket up here can get all of this information in a way that doesn't feel overwhelming and doesn't feel flooding, and can also create some space for some alternative beliefs to come into play. So things like, I made the best decision I could at the time, like your captain.
Right.
You know, I made this decision. I gave the guys the option. They wanted to be there because they wanted to handle it with the utmost respect and dignity. And it was hard. And so it brings in some space, and it helps the body to adopt the nervous system response to that. So instead of having this panic response every time that trigger comes up, it's able to recognize it as a trigger and still hold space for the new setting of it.
Okay.
If that makes sense.
It does. And you know, the thing that, as we're sitting here talking, it kind of breaks my heart to think every day this is happening thousands of times. There are horrific incidents happening that first responders, law enforcement, everybody, I mean, the military, you're exposed to, but a lot of people still have that old mentality of suck it up, deal with it, don't be a sissy. Those kinds of people I want to shake and just tell them it's not something that you can just suck up. This is a real legit thing. And the more that those kinds of people disregard it, the more suicides we have, and the more ODs we have, or the more divorces people go through, because they're not getting that attention. And I know for Modesto City now, they are paying more attention to it. But everything is a post-traumatic stress debriefing. Let's send somebody to some therapy after the event. What is there that's out there that can happen pre-stress event? Is there anything that people can do to understand this beforehand?
Yes and no. Early intervention is something that we know is key. So getting those debriefings as soon as possible. I'm going to kind of side answer your question initially. One of the reasons that it's hard to measure what doesn't happen, right? It's hard to look at somebody and say, you didn't get post-traumatic stress. Okay, what didn't happen?
Right.
What we know is that there are some susceptibility factors. So there are factors that make someone more vulnerable to experience a post-traumatic stress process. So when you see these kinds of things, everybody's going to have a response to it, right? You're going to get the song in your head for a while, but some people are able to process through it and move along without it becoming a traumatic memory that's locked in the brain with a post-traumatic response.
Okay.
Some of the things that we know, attachment comes into a big play. Did they have a healthy foundation growing up with caring and supportive parental units and family around them and that sort of thing? Or were they kind of left to their own devices? Were they left to their own comforts? Have they experienced problems with substance use in the past? Do they have a predisposition to avoidant behaviors? So are they someone that needs to socially drink a couple of drinks to socially kind of lubricate before they engage with conversations and that sort of thing? And what is their coping? Do they have a faith or a spiritual practice? Do they have a hobby that they can go and do that's away and separate from fire or law enforcement or military? What is their support system like? And we can kind of reverse engineer some of that if we need to and try to set it up after the fact. But having those things in place beforehand,
Wow.
astronomically different numbers that we see coming out from the other side of the exposure.
How interesting. Has there been studies to look at people before they go into a career that would cause something like this and to understand it?
Absolutely. So if people are interested in learning more, grit is a psychological concept. There's a book out there called Just Grit. I don't remember the author's name offhand, but she coined this kind of study and this idea back in the early 2000s and talked about that there are folks that just have kind of a natural born resiliency. There's folks that have a natural grit where they are able to persevere through some of these more challenging circumstances that others just don't seem to be able to have the same response to. So there's a lot of components that have gone into studying that. There's also a lot, again, with secondary traumatization. So did the person who's experienced the trauma right now, were they pre-exposed to post-traumatic stress? Were their parents in fire? We see a lot of family legacy, right? We see a lot of
Right.
legacy firefighters, a lot of legacy law enforcement, same with military.
Right.
And so there are studies out there where to start, and are they written for the everyday person or are they written for fellow clinicians? That's where it gets tricky. Most of them, unfortunately, are written for fellow clinicians, and they're pretty hard to sit through.
Wow.
They're hard for me to sit through reading, let alone someone else that's not trained in the jargon.
Right. I'm fascinated with this right now. I mean, I could imagine this conversation going a little bit deeper and taking a lot longer. I'm processing kind of how we've done this. It's just crazy to me how the human brain does that. It pushes things off to the side so that you don't have to be exposed to it or you don't have to feel it right now. If there's somebody out there that's going through PTSD or they think they are, what can they do right now? What would you recommend them to do?
The sooner you get help, the sooner you might save your career and your marriage. I think it's important to point out that people that are in less intense jobs, so less risk jobs, right? My CPA probably is not going to have the same probability of developing post-traumatic stress as a fireman. He might see something. He might have a personal experience in his life or his loved one's life that can develop that process. But his healing journey is going to look very different because the chances of that being an isolated event are significantly higher.
Right.
Okay. So for someone like you, that's just Tuesday. You still have a shift on Thursday. And so the brain is going to do what it has to survive.
Right.
But at some point, the brain cashes in the checks. And so when I first started in my career, the majority of my population, the majority of the people that I was treating were Vietnam veterans. They had gotten out. They had 3 or 4 marriages. They had 3 or 4 jobs at the same time. They had 30 years of substance use, and then they retired. And it all hit the fan because they would come in and they would say, it caught up, and it will catch you eventually. Your nervous system pays the price.
Mm-hmm.
It's just a question of whether or not it's going to go for another 100,000 miles or 10,000 miles.
Right.
And the biggest thing I hear is, I don't have the time right now. They need me for this next season. They need me for this next thing. At some point, you're not going to have a choice anymore. Your marriage is going to fall apart.
Yep.
Your kids aren't going to be talking to you. You're going to lose that career. You're going to have that nervous system breakdown. You're going to end up with, 2, 3, and 4 DUIs, whatever the case is. It's a very similar story time and time again that comes through my office. And right now, the challenges that I see for folks that are looking to take that step is accessibility. It's being able to afford the therapy.
Mm-hmm.
It's being able to get it covered by insurance. It's being able to get it frequently and frequently enough. Trauma therapy is intense. It should be often handled. So you should be being seen frequently. And if your person can only fit you in every 4 to 6 weeks,
Doesn't
it's
work.
not really therapy. That's
Right.
coffee.
Right. And it's never so bad that you need to look at that last way out. I just can't say that enough because there's always somebody that will listen. There is always another option. Don't take your life. Don't think that is a way to end the pain because there are other ways that can work and will work. There are people out there that can help. So the one thing that I would say is don't take that final step because it's just that. It's your final step. There's still hope. There's always going to be hope. Dr. Andreski, this has been amazing. I hate that I cry on camera and that it's going to be out there, but I think it's such an important topic that it has to be discussed. We have to open this door wider so that more people understand it. It's not looked upon as a weakness. It's something that, I don't know, you would call it a sickness or just something that you need help with that doesn't make you weak. I think
Yeah.
as firefighters, law enforcement, first responders in general, military hate the thought that they're looked upon as a weak person. Female, male, doesn't matter, because the personality that goes into that profession isn't the weak kind of personality. So to be described as, well, you're weak, that's why you need this help, isn't correct. It's more in depth with your brain and the way that your brain is allowing things or not allowing things to communicate with yourself.
Yeah, I think there's the accessibility issues. There's the willingness and the ability to look and say, okay, I'm deserving of having the time that I need to go through this process. It's admitting that your team's probably going to be okay without you for a while, and that's hard.
Yep.
And then getting back in there and worrying about perception. It's worrying about, am I going to be able to do this job? There's a lot of people who are afraid. In the military, there's certain positions where if you do tag into mental health, you're done.
Right.
And it's hard. And I would go back to your point about, suicide and things like that. There's this belief that people have where they don't want to burden someone else.
Mm-hmm.
And that's what we're here for. I spent 11 years in college learning how to authentically care and yet not be burdened and be able to end this conversation and go about my life, because I do my own therapy. I do my own work. And if you find a therapist who's not in therapy, run screaming, right, preferably the other direction. But that's what we're here for. We are here and we are specially trained. And those of us that go into trauma, it is a grueling process. But if we've made it this long, it's because we have done it well and we are good at our jobs and we're good at taking care of ourselves. And so my encouragement would be for anyone to make that call. Call the crisis line, call 911, call the suicide prevention hotline, whatever the case may be that's most appropriate for you, and get that help.
Right.
And if you need a buddy there with you, then tag someone in, but also get the professionals involved, because they're going to be the ones that are going to be able to step in and help process out what you experience.
Right. Okay. So we would really love to have you back on again. But before that happens, is there a way that people who are listening right now, or somebody who knows somebody that needs some help, can reach out to you? How do they get a hold of you?
Sure, absolutely. So I do have a website. I do have a private practice. I see the patients virtually, so I'm completely telehealth, and they can find me at just drsarahraeandreski.com. So that's DRSARAHRAEANDRESKI.com.
Well, again, thank you so much for your time. I really appreciate it. To all of our listeners, if you like this, please click that thumbs up button, like it, tell your friends about it, whatever you need to do. But Dr. Andreski, thank you very much for your time. I really appreciate it.
Thank you. It was an honor.
So Sarah Ray has left the podcast. What a great episode that was. This was emotional. It was therapeutic, and I look forward to the next one. I also want to thank Hermitage Dental Labs for sponsoring this. Nate, thank you for doing it. Everybody look them up. Give them some thumbs up and some love. Thank you.